So everyone's very excited that lung cancer is now, the treatments for lung cancer coming into the curative space rather than just the palliative nature, and that's around surgery. And for many years we've been trying to find a successful way of administering not just surgery but the whole sort of package of systemic therapies, radiotherapy around surgery. And the trouble has been in the past that patients are so debilitated after surgery that often we cannot give systemic therapies. Now the concept of neoadjuvant treatment has come in, which is preoperative chemotherapy and immunotherapy, and that's really a game changer and really has changed our clinical practice in the whole of the world. So at the moment in the UK we have approval for neoadjuvant chemoimmunotherapy only, but soon round the corner is going to be perioperative treatments, so neoadjuvant surgery, then adjuvant therapy. Now it's about trying to see how we fit this whole spectrum of patients in this early stage disease into which aspects. Does everybody need neoadjuvant therapy? Does anybody need adjuvant therapy, so post-operative treatment? And who are the people who need both? And that's going to be really the defining, I suppose in the next probably 2 years, we'll find out whether we can escalate and de-escalate in a personalized way. And that sort of leads me on to the ctDNA stuff that we've been talking about. So this is circulating tumor DNA from cancers generally, but in lung cancer this seems to be surplus and easy to pick up. There's a lot of commercially available tests as well as academically led institutions who are looking at that. So there's been an NHS pilot looking at circulating tumor DNA in the advanced disease. Now, I think we could probably, at the moment, it is only licensed in the advanced setting, and we can deep dive into that DNA and look at what drives the cancer, look at the DNA of that cancer, and potentially pick up treatment strategies much earlier than perhaps a tissue biopsy. And that can be used in relapse as well. So, once you've had a very good response to treatment, people then start progressing, and there may be a different mechanism of resistance, and another drug may be required for that. Now go back one step and think about whether we could use this circulating tumor DNA in this perioperative space. So is that going to work? Does lung cancer have enough circulating tumor DNA in this early stage disease? These are all questions that are important and need to be answered in research that's specifically designed to look at that. And so talking about escalation, de-escalation of treatment, those people who don't clear the DNA, maybe it's those people who really need that extra treatment. So maybe they need neoadjuvant treatment, surgery, adjuvant therapy. And those people who clear the DNA and have a complete pathological response, perhaps they only need the neoadjuvant therapy. So really making it personalized for that lung cancer patient.